Hello, everyone, and thank you for joining us for today's educational webinar. My name is Kathy Riley, and I'm the Associate Director of Programs at Cancer Support Community Los Angeles. I'm honored to welcome you today to this week's webinar titled Pediatric Cancer, Neuropsychological Testing, and School Reintegration. Before we begin, if this is your first time joining us, the Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer. It includes patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational events such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. And before I introduce today's speakers, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation, and we may not be able to get to all of your questions, but our presenters' contact information is in their slides. So let me go ahead and move on to our wonderful speakers for today. Bridget Vazquez is a clinical psychologist at Jonathan Jaques Cancer Institute. She provides a range of services to pediatric hematology and oncology patients ages 0 to 21, including consultation, psychotherapy, neuropsychological assessment, and reintegration services to facilitate a smooth and supportive transition back to school or work. Her clinical and research interests include pediatric health psychology, testing and assessment, trauma-informed care, and cultural sensitivity forms of coping. Teddi Softley is a clinical psychologist also at Jonathan Jaques Cancer Institute. And over the years, Dr. Softley has gained extensive experience in neuropsychological assessment, treatment planning, school reintegration services, counseling, and psychotherapy for children, adolescents, and young adults with blood diseases, cancer, brain tumors, stroke, and other chronic and acute illnesses that affect the central nervous system. She is dedicated to cancer survivorship, diversity, chronic illness, and determined to help individuals with special educational needs maximize their potential. And it gives me the greatest pleasure to welcome Dr. Bridget Vazquez and Dr. Teddi Softley.
Hi, good afternoon. Good afternoon, everyone.
Good afternoon.
Thank you, Kathy, for the warm welcome, and thank you to everyone joining us this afternoon for our seminar topic. I'm going to give me a second here to share our screen. This one is. Hi, Kathy. Are we showing a slide? Can you see slides?
We can see slides. You just need to be in presentation mode.
Okay. So sorry. Let's go something changed here. Terribly sorry. Okay. How about now?
Perfect. Thank you.
Wonderful. All right, everyone. Sorry about those technical difficulties. So again, pleasure to meet everyone this afternoon. Dr. Softley and I are going to be talking a little bit about pediatric cancer, neuropsychological testing, and how to prepare this population for, re-entry into a school setting. So before we get started, we just want to say that we have no actual or potential conflicts of interest with respect to this presentation. And today's objectives are really going to focus on providing an overview of common types of cancer and treatments, as well as reviewing the late effects that are often associated with pediatric cancer treatment. We're going to provide an overview on what is neuropsychological testing in pediatric oncology, namely common domains that are assessed, and what the goal is, as well as discussing school reentry following either a cancer diagnosis or treatment. So Dr. Softley will be talking to us a little bit about different childhood cancers.
There are many, many different types of childhood cancers, and we would like to specifically just briefly discuss the common types. Many of you may know that leukemia is the most common type of pediatric and adolescent cancer, and within the leukemias, the most common type is acute lymphoblastic leukemia, and there are many, many subtypes of what we call ALL. Next, we have AML, and within that category, there are basically 6 subtypes. In addition to that, we have chronic myelocytic leukemia, which is more rare, followed by brain tumor and central nervous system tumors. And again, there are many, many, many types of brain tumors that occur in young children, school-age children, and adolescents. Some of them that we see are astrocytomas, ependymomas, and medulloblastomas, followed by craniopharyngiomas. And I must state that medulloblastomas are the most common malignant brain tumors in children. Next, we have lymphomas, and that includes non-Hodgkin lymphomas and Hodgkin lymphomas. And within the non-Hodgkin lymphoma category, there are many, many types, such as Burkitt's lymphoma and large cell lymphoma, followed by our solid tumors, including germ cell tumors, kidney cancers, liver cancers, neuroblastomas, and soft tissue and bone sarcomas, such as rhabdomyosarcoma, Ewing sarcoma, and osteogenic sarcoma. Next. There are many treatments for childhood cancer, and some cancers only require surgery. Others are involving multimodal treatments, including chemotherapy, radiation therapy. Some may require stem cell transplant, bone marrow transplant, newer combination therapies, including immunotherapies such as CAR T-cell treatment, other target therapies, palliative care, and many may consider alternative treatments.
Okay, so Dr. Softley is going to talk a little bit more about, what contributes to outcomes, right, and late effects. But I'm just going to give you guys a bit of an overview here. There are many different contributing factors in terms of what might lead to neurocognitive and psychosocial outcomes. It might be, the chemotherapy. It could be brain tumor and its location. It can be comorbid conditions, adverse effects of treatment, a combination of factors. And, you know, what the research does tend to show is that some patients may be already exhibiting cognitive impairment before treatment. Some might have noticeable changes as a result, you know, either during or as a result of treatment. Other patients, some of these impairments might resolve over a short period of time, and other patients may have more long-term effects, right? So typically what we observe in the literature is many patients do report changes or deficits in their intellectual functioning. They might notice also decreased processing speed, where I think very commonly a lot of our kiddos tell us, like, geez, it takes us a little bit longer now to think about information, or it's taking me longer to read or finish a timed in-class assignment. So these might be some signs of changes in processing speed. Also noted is, you know, possible difficulties in learning and memory, right? Where some patients might notice that they're having a harder time holding on to information, encoding it into memory. This might be information that happens in auditory forms, just like listening to a classroom lecture, to visual information, such as remembering maybe information that are presented on a PowerPoint slide. And so many times, patients will note that they're having trouble learning and remembering information overall. We also note that there's deficits in attention, where maybe patients find themselves having a harder time sustaining focus and attention, being easily distracted, finding that it's kind of hard to block out noise and focus on work. Some might even say like that they feel very overwhelmed when they're provided with a lot of information at once and not really sure where to focus their attention. Executive functioning deficits are also noted, particularly in an area called working memory. So many times patients will note that it's really hard for them to multitask, or being able to remember a phone number or items from their grocery list. They might need repetition of instructions or information. They might have difficulty following tasks that require a lot of steps. Other areas that might be impacted is, you know, difficulty with being flexible and shifting, preparing to a next activity, or completing complex tasks, or making the same error even though you're getting feedback from your environment that, hey, it's actually done this way, right? Other areas might be difficulty with planning and problem solving, really regulating your body, sitting still, and being able to make decisions after stopping and thinking. Just a couple more learning problems. So academic difficulties, patients might know that they're having a hard time reading or completing complex math problems, even writing, and visual spatial problems such as being confused between what is right and left, you know, like letter reversals, and a hard time perceiving part-whole relationships. We also know from the literature that our pediatric oncology patients and survivors are at increased risk for psychosocial problems, including anxiety, traumatic stress symptoms, suicidal ideation, behavioral difficulties, and also just relating socially.
Now we'd like to move on to some of the causes of neuropsychological late effects. One of the most important things to remember is that chemotherapy, radiation, and even surgery can insult a developing brain. For example, cranial radiation can cause specific damage to the brain and related structures. Central nervous system directed chemotherapy can often cross the blood-brain barrier, and that can impact specific areas related to language, memory, attention, and executive functioning. In addition, tumor resection, depending on the location, can sometimes result in excessive brain tissue being removed. It can even affect an artery or vein, causing excessive bleeding, hemorrhaging, and even a stroke, depending on the area. There are other factors associated with neurocognitive and social outcomes. Some of these include the severity and extent of the cancer, the features of the tumor. For example, a tumor can be very localized. It can be removed successfully without affecting other areas. On the other hand, it can have little tentacles and be very widespread, affecting an entire area of the brain and difficult to remove without damaging arteries, veins, and other significant areas. There can also be comorbidities and pre-existing conditions such as trisomy 21, also known as Down syndrome, which often occurs in acute lymphocytic and acute myelogenous leukemia. There can be complications simply with surgery, chemotherapy, and other issues. The age and sex at diagnosis can be extremely important, with younger children being impacted and sometimes older children being at higher risk. In addition, genetics can have a significant impact on the diagnosis, and we're learning more and more about genetics and the impact on diagnoses and type of cancer. And since I've been working here a long time, I've come to realize that now more and more patients are undergoing genetic studies and chromosome analysis of their tumors at diagnosis, and they're able to target the chemotherapy to make it more effective to ensure that more and more patients are cured from their diseases. For example, we have the p53 gene. We have patients who have genetic diseases such as Down syndrome, and we have the Leigh-Van-Willy syndrome and other syndromes which make you at greater risk for certain types of cancer. And we have cancer treatments which are known to cause cognitive late effects, such as Decagon, methotrexate, and other types of treatment. And it depends on the type of chemotherapy, the dose, and the type of administration. In addition to that, we have toxicities, which can cause very acute and eventually long-term toxicities. Again, methotrexate and Decagon are known to cause toxicity in some of our patients, but it's very rare. But we are able to minimize some of the cognitive late effects by assessing patients early on and providing good rehabilitation and special education to help these patients. There are other complications which even occur in a rare group of patients, and with research and participation in studies, some of these patients are able to have their doses and chemotherapy change to minimize side effects. Lastly, surgical resection can cause complications, so it's important to work very closely with the surgical team to carefully map out a good plan in order to minimize surgical complications. So neurocognitive and psychosocial outcomes additionally have other important features. We want to look closely at early childhood development to find out what level of functioning the child had prior to diagnosis. We want to look at their pre-cancer level of functioning. If they had some cognitive or physical delay, we often provide aggressive support while they're in the hospital, such as physical, occupational therapy and speech therapy to help maximize their potential and minimize long-term deficits. We provide educational experiences during hospitalization and while they're at home recovering. And if they can go to school earlier, we try to include that. We increase socialization and social engagement, and we provide assistance to help them adjust and cope appropriately. We also look at the family and environmental support and work with different agencies, including yours, to help provide different support systems and keep those in place as long as they're needed to help the family cope. And again, we provide educational services such as home and hospital instruction, tutoring, and rehabilitation services to help maximize patients' potential. And following that, survivorship care is incorporated through most of the centers throughout Southern California. Common diagnoses that psychologists see when treating our cancer patients during treatment and during survivorship include what we call mild neurocognitive disorder. And this is a modest diagnosis, which includes a decline from previous level of performance in a range of cognitive areas. This cognitive decline does not interfere with a capacity for independence in everyday activities. On the other hand, major neurocognitive disorder is defined as a decline from a previous level of performance in a range of cognitive areas, and it does interfere with the capacity for independence in everyday activities. So there is a difference, and some individuals that have major neurocognitive disorder may have had an existing impairment prior to diagnosis, or they may have had a significant decline due to some unusual factor during their treatment. Other diagnoses include specific learning disabilities in one or more areas, and these learning disabilities can include or impede abilities to learn or use foundational academic skills, for instance, in reading comprehension, mathematics, and written expression. And there are cross-cultural conditions that typically persist into adulthood. Then we have attention deficit hyperactivity disorder. Some individuals may have a history of ADHD at diagnosis, and right now we know that approximately 5 to 6% of the general population has this diagnosis, and some of our patients who receive chemotherapy, especially chemo that crosses the blood-brain barrier, may look as if they have ADHD after they complete their treatment, for a brain tumor, lymphoma, or leukemia, but we have to make a careful diagnosis and complete neuropsychological testing to make sure they do not have mild or major neurocognitive disorder and not an ADHD diagnosis. And ADHD can interfere with functioning or development and can begin in early childhood, and it must manifest in more than one setting. Next slide.
Okay, so we're just going to talk a little bit about some interventions for both neurocognitive and psychosocial late effects. So as you guys can see, pediatric cancer treatment can impact quality of life, right? And so this in particularly when we think about school, it can have a detrimental impact in how patients are functioning throughout their academic careers and further. So one standard of care, right, for a lot of pediatric oncology centers is to conduct a neuropsychological testing battery. And ideally what we're trying to see is basically the relationship between brain functioning and behavior, right? Typically a battery, it's very comprehensive, and some common areas that are evaluated in this battery are intelligence, again, learning and memory, how one pays attention, different aspects of higher level functions called executive functioning, language. This includes both spoken language and receptive language, academic achievement, different areas of visual sensory, perceptual motor abilities, behavior, emotions, personality, as well as adaptive behaviors. And again, the goal when we're conducting these batteries is really just to hone in and get a better understanding of how an individual is functioning, right? We're really hoping to get a better understanding of what are your strengths and maybe what might be areas that might be a little bit more difficult or challenging. We're really trying to understand, how current functioning is impacting learning, whether if current cognitive functioning is related to either neurological or medical conditions. Is it related to your cancer directly? Is it related to treatment or a culmination of these factors? And once testing is completed, there is a written profile that is put together, which is then utilized to help inform treatment planning with your physicians, care team members, as well as really collaborating with different disciplines on the accommodations. So at the completion of the battery evaluation and the results are discussed with parents, guardians, and typically anyone who is involved with an individual's treatment and ongoing care. And for us, it often includes a lot of collaboration with school.
And when we look at neuropsych testing, it is important to look at the ability level, which is your intellectual or cognitive capacity, and look at your academic functioning. And a lot of the time, parents or educators will say, Johnny is doing well academically, so he's at grade level. And that's what we like to see. But sometimes there is a discrepancy, and our patients may be significantly behind their peers. So that's why it's important for us to assess the ability level. Where should they be functioning? And treatment side effects, psychological or psychosocial stressors, and school absences during and post-treatment may impact learning and educational outcomes among our oncology patients. So we need to know what their ability level is first to see what their potential is and what capacity they have to learn. So we may have that history in advance if they have had a prior evaluation, if they have a history of ASD, intellectual disability, or some other condition. However, we may not have any history at all because many public schools and even private schools do not assess intellectual ability. So fortunately, we are able to do that. And sometimes we have a child that has been evaluated by regional center and they provide that information. So we actively collaborate with educational programs, public, private, and charter schools to provide our information with the parents' permission to provide appropriate academic accommodations. And that can be done on an elementary, preschool, high school level, and even college level. So our goal is to collaborate and coordinate school services between the hospital, school, and family, provide tools, strategies, and resources to optimize educational and future vocational outcomes. And we want to maximize the potential in all of our patients, no matter what it may be. We want to educate school staff about potential acute and long-term medical and psychological impact of treatment, and educate classmates about medical illness, conditions, and treatment. And we do this through implementing a 504 plan, and a 504 plan is what is called Section 504 of the Rehabilitation Act of 1973. And this act has been modified over the years, but basically it is under the federal civil rights law to stop discrimination against individuals with disabilities. And it is available to all students in the United States with a disability requiring reasonable accommodations, supports, or services in a regular education program. And this can be from preschool on up through college or graduate school. And a 504 plan is created and reviewed by a 504 plan committee of individuals, which may include guardians, school staff, including the principal, teacher, counselor, nurse, 504 plan coordinator for a district, and others familiar with the student. And it should be reviewed annually and revised as needed, even if it needs to be revised within a month, 2 months, or 6 months. And private schools that receive financial assistance from the federal government are covered under this law. An individual health plan can be included in a 504 accommodation plan. And this written plan between a school nurse and the student's guardian describes the student's health condition and how it should be managed within a school setting. It may include the student's diagnosis, treatment information, emergency protocols, and emergency contacts. So if a student has a complicated leukemia history that involve seizures, an infection, different medication, hypertension, et cetera, they can have an individual health plan as well as their 504 plan, and it can be part of an IEP as well. But everyone with leukemia does not need an IHP. Moving on to an individual education plan, this is also covered under the IDEA law and federal special education laws for children with specific disabilities. An IEP is available to students with disabilities, which can be medical or mental, whose needs cannot be met in a regular education class with a 504 accommodation plan. This provides individualized special education and related services to meet the special needs of the student. And a written request is for an IEP is mandatory. A written request is also mandatory for a 504 plan. If a child, for example, is 3 years old and they need speech therapy in a school, it falls under the category of an IEP. If they're under 3, they can receive speech therapy through a regional center under their designated district in the state of California. An IEP is held when the school gathers appropriate information from all outside sources and performs an evaluation. An IEP meeting is scheduled and recommendations, goals, and objectives are discussed. Students qualify for services under one or more of the 13 categories listed in IDEA, and reevaluations occur every 3 years. Students are eligible for services through age 21 or until high school graduation. And most patients with cancer qualify under the major category of other health impaired. They can also fall under other categories such as orthopedically handicapped, visually impaired, or deaf and hard of hearing, and multiple other categories. Next slide. Sample academic accommodations include medically excused absences, extra time for tests and quizzes due to decreased processing speed, delivering tests and quizzes in verbal format versus written due to visually impaired, needs provision of a designated note taker, permission to audio record class for later review. Student program and services refers to disability programs for college students, and these are designed to provide accommodations for students with disabilities on college or university campuses, and students must provide verification of their medical and or mental disability. Some of the services may include a note taker, priority registration, books on tape for individuals that have a significant reading disorder, or Braille for individuals that have visual impairment, so forth and so on. Next slide.
Okay. So, so far we've learned and talked about different types of areas of neurocognitive functioning impacted by either the cancer itself, cancer treatment. We've also talked about, some academic interventions that are available to help support our pediatric cancer patients and survivors. Another type of intervention is called neurocognitive rehabilitation, and these interventions are really focused on attempting to improve, if not address, some of the areas that we've talked about previously where we're noticing some deficits. So there's still a lot of research yet to be done on the benefits of neurocog rehab programs or interventions, but there is research to support at least short-term improvements in some of these areas. So, for example, like computerized cognitive training programs teach different skills to help address like working memory. Sometimes, interventions might work on helping to build up a skill to help address learning and memory deficits, right? So learning different strategies on how to improve like your study skills, right? Other interventions might work on compensation strategies, right? So learning how to better organize yourself so that you don't miss those deadlines, or how to double check work for errors or completion. So again, preliminary research and early research here has shown that these do work on making improvements in both in working memory, attention, and different areas of executive functioning. Some other interventions to help with both neurocognitive and psychosocial late effects include supportive therapy, so mental health services ranging from individual therapy services all the way to social support groups such as those offered here through Cancer Support Community Los Angeles. And research has shown that for those that do participate in therapy, some of the more evidence-based interventions with this population in particular include ACT, which is acceptance and commitment therapy, cognitive behavioral therapy, also known as CBT, as well as other mindfulness-based strategies. And last but not least, other resources that have been shown to be beneficial to this population include mobile applications that really focus in on teaching skills such as breathing and relaxation, learning how to meditate and be grounded, as well as guided imagery. So maybe imagining a safe space or a place that makes you feel calm and soothed and comfortable. And of course, there's always medication management services in which our patients are encouraged to reach out to either primary care physicians or someone from the team for psychiatry referrals. Just really quickly on the mobile applications, I believe that there's been a little bit more research on applications such as Headspace, Stanvello, I believe, is another one. So just some options there. So I believe that wraps up the educational component of our presentation. We are more than happy to answer any questions with remaining time.
Oh, thank you so much for that meaningful and informative presentation. We want to take questions from all of you, so please, if you see the Q&A feature at the bottom of the Zoom window, please feel free to type your questions in there. We have about 10 minutes or so for questions. And I'd like to start with one. You talked about neuropsychological testing. How often do you recommend a child who's been through cancer treatment receive a neuropsychological evaluation?
It varies. There are many centers nationwide that perform neuropsych testing at the onset of treatment and completion of treatment for every patient on a clinical trial, but others only request it when a child is having difficulty. We like to incorporate neuropsych testing for our patients who are officially on a study or for those who exhibit symptoms and are having difficulty?
Just to add to that, so we, when at all possible, we'll do baseline testing, so either right before treatment or very early on, so that we can get an idea of what current functioning is looking like. And then we might do testing post-treatment. And again, that might depend on whether typically on diagnosis as well, and where they are in treatment. Other times we encourage our families to contact us if they notice any major changes in their child's functioning. So maybe all of a sudden Johnny is exhibiting, difficulties focusing, or now he's not turning in any work, and this is a big change for him. It might be a good indication to contact the provider and see if neuropsych testing is recommended, follow-up neuropsych testing.
In addition to that, I must say that we like to perform neuropsych testing for all high-risk patients pre-treatment. And that could be a high-risk brain tumor, leukemia, and/or lymphoma. And now we are trying to incorporate that for the osteogenic sarcomas, and any cancer patient who receives a treatment that includes chemotherapy that crosses the blood-brain barrier, like IV methotrexate.
And then a follow-up question to that is, how much of a struggle is it to get insurance companies to cover neuropsychological evaluations? Has that been a struggle?
That is a struggle, but when you include the terminology that this is standard for pediatric oncology follow-up, and if you include the citation from the Journal of Pediatric Oncology that mentions that standard of care that was quoted how many years ago? I think it was about 7 or 8 years ago when they created the standards for appropriate care for pediatric oncology, and they're trying to generalize that to all pediatric care for chronic diseases, including diabetes, cystic fibrosis, and epilepsy, and a few other diseases.
And that's the psychosocial standards of care, correct?
Yes,
That's correct.
yes.
Well, that's correct.
And then sort of following the thread of the neuropsychological evaluation, what strategies do you recommend for families working with a school that might be resistant to following neuropsychological evaluation recommendations or modifications?
It varies, and we can both talk on this. I've been around a long time, and we attempt to be pleasant. And I'll give LAUSD as an example. It varies so much, and it depends on the region of the district. And I can go in on any day and say that I've administered tests. I would like to share my results with your school's testing, and I can get a positive attitude or a very negative attitude. And then I will ask the family to talk to them, and we work as a team instead of being antagonistic. And then giving me a negative attitude and saying, we can't use your test scores. But I recently had a very welcome reception in a South Bay school, and they were very accommodating, very receptive, and wanted the neuropsych testing as quickly as possible. And I was really shocked, but very, very welcoming.
I think just to add to that, Kathy, is persistence, right? I really encourage all families to not take no as the final answer, right? You have a team to rely on. If it's available, at times, sometimes, for example, like our team, we try to be present to those meetings, right? We will help advocate for you if you're dealing with special education and they don't want to integrate your recommendations in the current IEP. Remember, you don't have to sign the IEP if you're not in agreement, right? You can continue to take it higher and higher, to the district and really advocate for your child's needs. So, just don't become discouraged. We encourage you to be an advocate and reach out to your team members to see if they can also participate in these meetings for you or with you.
Thank you. Great advice, great strategies. And let's talk a little bit more about the late effects of treatment. You covered some of those in your talk. And thinking of time frame, if a family is watching this webinar, and how long does it take to see late effects from treatment of cancer, is sort of part one of the question. Then part two, are there improvements over time, or do things stay the same or potentially worsen?
It varies. And, I started to think about including acute effects and late effects, because sometimes you see acute effects of treatment. You may see steroid psychosis, because initially you may receive high dose steroids and patients may have problems with that, and then they get better. They may have high ammonia levels from 6-MP, and that may resolve, and we worry about their neurocognitive functioning, and it improves. And we closely monitor to see if there will be residual late effects, because sometimes they're incoherent, they're almost comatose, but they get much better. So that is acute toxicity. And I've seen parents worry more and more about that initially, but the patients seem to recover. And then we say, oh, maybe we should test. And then they don't want testing. Johnny has improved so much, and they're back to baseline. But then sometimes you don't see late effects for a long time. When I started working here in the late 1980s, early 90s, my first case was a young woman who received cranial radiation for ALL, and they all did at that time. She didn't have late effects until she went to college. And I had to go to her school and explain what radiation could do to the brain. And she didn't have any difficulty until she was working on her master's. She was able to compensate and do well. But it was probably because she didn't have any difficulty until she encountered higher level learning problems. But with other children, some of them encounter difficulty a year after they finish treatment, if they're younger.
I
But-
believe that, oh, sorry,
Go
Dr.
on.
Softley, I was about to say, and I think that the research trend tends to indicate anywhere between 5 to 7, about like 5 to 7 years post-treatment, you might start to see emergence of late effects. So kind of keeping an eye during that time frame as well.
And sometimes it's providing parents skills and information on what to look for and what to do with their children at home. And some parents want them to get right back into school, and sometimes that helps, but others prefer to keep them at home. And if they work with them at home, that can help too. So it just varies.
And then I think one final question before we conclude the webinar. What do you find most hopeful in your work today?
Great question. It's a great question. Sorry, go ahead.
I can say for me, since I've been here a long time, what's most rewarding is to see that research has moved us along and more children are being cured, more children are surviving, and there's greater hope for brain tumors. More and more brain tumors are doing a lot better, and more patients are getting work, going to school, finding meaningful employment. But we still have a long way to go with other types of cancers. And I'm just wondering why we can't get there. Why can't we cure more osteogenic sarcomas, the complex brain tumors, and solid tumors? What can we do to treat them? And hopefully one day we will get there.
Right. I mean, I want to echo that, just hopeful to really being able to support our survivors, right? I mean, cancer comes with the increase and improvement in medical treatment. Survivorship comes with the cost. And I believe, I'm hopeful that, we will continue as multiple disciplines to be able to come up with the research and resources to really help and support our patients and families post-diagnosis and beyond.
Well, I'd like to thank you both, Dr. Vazquez and Dr. Softley, for your meaningful presentation today. We've reached the end of our time, and I also would like to thank our attendees for their engagement with us today. If you would like to receive a copy of today's slides, I have put our email in the chat, and that email is info@cancersupportla.org. And we look forward to seeing you at a future webinar. Thank you, everyone.
Thank you.
Thank you so much for allowing us to present, and we would be willing to work with you at any time in the future.
Wonderful. Thank you.
Thanks for the
Thank you.
opportunity.
Bye-bye.
Bye-bye.